Thank you. Thank you. Thank you. So now before beginning the topic, here is a disclaimer that we need to put before you. That is, the contents has been generously supported by the World Confederation of Physical Therapy and the World Health Organization, and also by Niti Aayog for telemedicine. That's for India. And the latest updates for telerehabilitation in view of COVID-19 may change from time to time. So it is advised to follow the guidelines laid down by WHO, WCPT, national, state authorities, as well as associations or councils. Next, please. These are the objectives of the session. I'll be deliberating about definition, scope, entitlement of practice, telerehabilitation application, modes, and the technology. And rest part will be taken by the second resource person, that's Dr. Jitnder Munjal. Going ahead. The definition for the telemedicine, as is written, the delivery of healthcare services where distance is a critical factor. Distance is a critical factor by all healthcare professionals using information and communication technology for the exchange of valid information for diagnosis, treatment, prevention of the disease and injury, as well as for research and evaluation and for the continuing education of the healthcare providers. And this is all in the interest of advancing the health of the individuals and their communities. So this is overall about the telemedicine where the doctors, nurses, and rest of the healthcare professionals will fall. Derived from is the definition of the telerehabilitation, that is the delivery of the rehabilitation services over the telecommunication network and the internet. Most type of services fall into two categories, that is clinical assessment, the patient's functional abilities in his or her own environment. This is very pertinent to say, the assessing the patient's functional abilities in his or her own environment, and thus the clinical therapy. Now see, knowingly or unknowingly, we were doing this before as well. Seldom we knew that this will evolve as a practice in itself. So at this point of time, I would like to know, when did WCPT officially came with the idea of digital physical therapy? Can anybody vague guesses in the chat box? You can put vague guesses in the chat box. Anyone? Because this was even before COVID-19. As I said, knowingly or unknowingly, we were doing this. So anyway, I'll answer this. That is, before the COVID-19 crisis in 2017, the World Confederation of Physical Therapy launched a collaboration to develop the initiative to the global practice and regulations of the digital physical therapy practice through a joint WCPT Digital Therapy Practice Task Force. And this report was published in 2019, and it defined the practice as healthcare service, support, and information provided remotely via digital communication and distance. Thus, even globally, there is no well accepted definition for digital physical therapy among the policymakers, stakeholders. The variety of technologies that encompasses this term may include teleeducation, telemedicine, telemonitoring, teleassistance, mobile health, etc. So there are yet the guidelines to evolve. Whatever we are discussing today are the proposed guidelines. Now, what is the scope of telerehabilitation? The scope is for the diagnosis of a problem, for the treatment of a disease. Like, let me take an example. Say if a patient with a stroke was referred to a physical therapy service. Now his caregiver gives me a call and says that this is a patient, so what are we supposed to do? Now see, if I just simply get a call, am I able to diagnose the patient of a stroke on the call? How do I know how much voluntary control does he have? Will the patient be able to stand on his own or not? So therefore, I have to think about a medium by which I would look at his problems. So I have to see the type of the technology that I can use. I'll give the examples further in detail. Going ahead, prevention of disease and injuries. Telerehabilitation will also help us in preventing the disease, because you might have seen a lot of webinars on how to prevent the injuries. We can deliberate on these also deliberately, and we can discuss deliberately on telerehabilitation, that how we are not supposed to incur injury and diseases. Research and evaluation. There have been various RCTs when we were studying this particular topic, various RCTs by different groups, and even various systemic reviews by WCPT in terms of research and evaluation for continuing education for healthcare workers also, and for us to have a lot of data so that we could research further. Therefore, telerehabilitation can deliver therapy to people who cannot travel to a clinic because the patient has a disability or because of the time. Like, as I just gave the example of a stroke patient. If the patient was disabled, he does not have the voluntary control on his body, obviously he's not able to come to my clinic. So that means that is not just because of the COVID. However, telerehabilitation also allows experts in rehabilitation to engage a clinical consultation at a distance. That means that is the need of the hour. Right now, whatever we are practicing will enhance because of our telerehabilitation. Next, please. Now, what are the various disciplines and therapies when we talk about telerehabilitation? It can be speech language pathology, it can be audiology, it can be physical therapy, our own branch, occupational therapy, our peer group, the psychologists, the nurses, the social workers, the rehabilitation counseling, and the vocational rehabilitation. Go to the next, please. Who are entitled to practice telerehabilitation? Any rehabilitation worker from the listed list which I gave you on the next previous slide, who is registered with the national, state, local, council, association, or body. Like, for example, for us in India, for the physios in India, if we are registered with, say, Delhi Council of Physical Therapy, Gujarat Council, Maharashtra Council, or even our national association, IAP, we are registered, so therefore we are entitled to practice the tele-rehabilitation. This is for ensuring the rights and to make it legal. Next, please. Now, what is the purpose of telerehabilitation? Now, this is the foremost thing that we got to understand. Very important thing that we got to understand, that the purpose of the telerehabilitation is basically to cure a patient by means of patient evaluation and patient management. Now, the same example, if I had to take here in terms of, say, stroke, or say low back pain, or say any tendon injury. Now, on a telephonic consultation, if I am told that patient is having, say, simple knee pain, and if it was possible for me to draw the information from the history that I take on the phone, and patient is educated enough to tell me the details, so maybe it is possible for me, even just for a telephonic consultation, to evaluate the patient and come up with the diagnosis. But the same stroke patient that I was exemplifying previously, I said that it will not be possible for me to do it on a telephonic conversation. Maybe I have to do a video call. On a video conference, I have to look whether the patient is having voluntary control or not, how many caregivers are there in the environment, and is his environment safe. So there are lots of factors that I have to consider before I will make a final judgment about the patient evaluation. So for the first consultation for telerehabilitation for any new patient where you are not sure, you must make video consultation. Then is patient management. This patient management can be for the same patient, or this patient management can be even for the patients who were visiting you before as well. Because for them, it is easy for you to manage them on the phone. Either you may make the videos which are already with you and just send them. So that is the asynchronous method that you will be using. However, for first time evaluation for the patient, you will always use a synchronous method. So there are two very essential methods, synchronous method and asynchronous methods, which I will be discussing in detail further. Next, please. Now, practitioner must consider the goals for the consultation. As I just said, that it is the client's safety which is paramount. Giving the same example back in terms of stroke patient having not known his voluntary control, and if I ask him to ask his caregiver to make him stand, and God forbid if something happens to the patient, so who will be responsible? It will be me. So I have to weigh the benefits versus the risks. That means my first client consultation will be over a synchronous mode where I will judge all the parameters so as to ensure the client's safety. And then only I will proceed further. Next is appropriateness of available technology. Now let me give you a different example. If a client from a low socioeconomic status gives me just a call and then says that he has got this X problem, so that means it is for me to judge how will I be able to help him, because it is also my duty as a clinician to not just neglect any sort of case. I have to look at the options, whether I can call him in person for the checkup if possible, or whether I have to make a video call. So definitely that will guide me better towards the first consultation. Then comes the benefit versus the risk. In the similar patient, as I was saying about the stroke, I cannot let him lose. That is, I cannot just think that, okay, that if the patient is not having availability of the video conferencing, I will not give any benefit to the patient. No, that's not right. That is not at all ethical. So I have to make the arrangements for the same. So I have to evaluate the patient on a video conferencing and make sure that the benefits are more than the risks. Next is clients and service users preference. Like I just said that initially they were preferring to just give me a call, but it was for me to decide that no, I have to make a video call. So I have to come to a mutual consensus what I have to do for the successful teleconsultation, telerehabilitation. Next, please. These are the 10 most important E's for the successful telerehabilitation. Number one is efficiency. Overall, it has been seen that it decreases the cost of the consultation because you are saving your travel cost, you are getting the consultation at your place where you are, and it is also said that even in the countries like US and all, the cost for the teleconsultation is much cheaper than the physical consultation. We have to ensure the quality of care. So that doesn't mean that if we are decreasing the cost, we have to compromise on the quality of the care. No, that will not do. And it has to be based on certain evidences. And thus, we will be able to empower our consumers, our customers, our client, because they will obviously get confidence in us that whatever we are practicing is a gold standard. It will also give us an opportunity for encouraging new relationships. Like, for example, if a physio who was not doing a teleconsultation gives me a phone call that, okay, you are doing it. So I will also establish a relationship with a peer group, members of the healthcare team, etc. It is also giving us an opportunity for educating. So we are not only educating a patient here, we are also educating his family, caregivers, other healthcare workers, etc. It also enables the information exchange. So naturally, unless and until we will keep everybody informed, we have to assure that everyone is informed so as to take care of our offline. It also gives an opportunity to deliver extension care. What does extension care mean? Like, for example, if the patients were already coming to you before COVID-19, they still want consultation from you. So how will you give your teleconsultations? You have already stored various videos as a professional with you. You use asynchronous mode, send them those videos, and they will definitely utilize those videos to know what type of exercises they have to do. So this is extension of activity. Yes, it may evolve as e-camps later, but right now we are not giving any information regarding that. Next is ethics and equity. These are the paramount. These are the first things that one has to keep in the mind. That is, the principles of ethics are the first things that we have to look at whenever we are giving the teleconsultation or telerehabilitation. And equity means that we have to give equal access to everyone, irrespective of their socio-economic status, irrespective of their how and what they are practicing, irrespective of their level of competence, irrespective of everything. And it also gives us an opportunity to make it easy and make it entertaining and exciting for patient. Otherwise we were not using any 3D or say any such kind of models with our patients in routine who are coming to our clinics. But here we can use certain exercises where we can make it more entertaining for our patients so that they can get exciting. They feel more excited to use the teleconsultation. Like, for example, video games, etc. There were only few people who were using those before. Next, please. Now is the technical part. Till now, I was detailing about what it is. Now, how to do this is the technology or the modes of the communication, the types of telerehabilitation, as I was stating before, the asynchronous mode and the synchronous mode. Asynchronous mode is also called as store and forward. Like, for example, I will store a video of certain exercises and then just forward it to the patient. That is called as asynchronous mode. And what is synchronous mode? It is real time. That is, I will call on a video conference and then I will see how much impairment does the patient have, how much disability does the patient have. If I'll ask him to raise his hand, I will judge what is the range of motion, is the limb flaccid or spastic, what is the level of the dysfunction. So that is what is synchronous method. I will discuss about these two methods in detail further. Go ahead, please. Please go ahead. Now, before I discuss details about synchronous, asynchronous, I need to classify the applications of telerehabilitation. Classification of telerehabilitation application. That means it can be based on according to the mode of communication that I was just telling. Then it can be also based on timing of the information transmitted. It can be based on purpose of consultation. It can be also based on interaction between the individuals involved. Now, I will tell you each one in detail. Please go to the next one. Next, please. Now, the first one, according to the mode of communication, that is number one, video. Here, telemedicine facilities, apps, videos on the chat platforms, Skype, FaceTime, etc. could be used for synchronized mode. Audio could be used for an asynchronized mode, and text-based can again be used for the asynchronized use. Text-based is specialized telemedicine, smartphone apps, websites, or other internet facilities. And then general texting, whether it is in the form of Google Hangouts, WhatsApps, Facebooks, etc. The social media, where you are only texting and therefore calling it asynchronous. It can be even the emails and the faxes. Next, please. Now, according to the time of information transmitted. Now, here there are two ways, like real-time video and asynchronous way. It is again the repetition of the same. Real time is where you are doing the video conferencing, there is audio, text, everything. And asynchronous is just exchange of the relevant information. That is video and audio It can be also in the form of video and audio, but that video you have already made and there is a time lag and you've just forwarded it. And then there could be a transmission of the summary of the patient complaint, supplementary data including images, laboratory reports, radiological investigations, etc. That means you can also visualize the lab reports. You can also visualize the supplementary data, whatever you want to look at. Say maybe you want to know details about a case retro in the past. So you already have that with you. That's the advantage. And such data can be forwarded to different parties at any point of time and thereafter accessed by their convenience. Next, please. Go to the next, please. According to the purpose of the consultation. So for non-emergency consult, now we have to judge whether the patient is consulting for any emergency or not. That means if it is a case of follow-up, so we will have to decide about the mode. And it is very simple because we know the entire history, we know about the diagnosis, we know everything. So say for example, any patient has a very simple pain. So naturally it is not an emergency and we can take care of this particular patient on a simple phone call. Now, emergency consult for immediate assistance or a first aid. Now, for example, there is a patient who has had a fracture. Say fracture both bone, low leg. Okay. And he has simply called you because it was only you who came he could strike your name in his mind and his caregiver gave a call to you that it is a COVID period. We are apprehensive to go to hospital for a consultation. So therefore we have called you. So what are we supposed to do? But as a physio and as a professional, I know that this is an emergency and we just cannot delay this. And we will advise him to do a first aid. That is, we'll just ask him to do some strapping, to place the segments in alignment and take the patient immediately to the hospital. In case alternative care is not present, teleconsultation might be the only way to provide timely care. In such situations, the professional may provide consultation to their best judgment. As I said, even for providing first aid, we have to ensure that yes, the caregiver is not someone who doesn't know anything. Will he be actually able to strap and give the cold pack or not? Then the teleservice should, however, be avoided for emergency care when alternative in-person care is available. So I know that yes, the clinics are running right now. Now the services of healthcare are already open. Therefore, teleconsultation should be limited to first aid, life-saving measures, and counseling and advice on the referral. So therefore, this example was appropriate for referring it to the right person. So in all the cases of emergency, the patient must be advised for in-person appointment. Next, please. Now, what is the broad framework for telerehabilitation? The framework can be in the following scenarios: patient to patient, caregiver to physiotherapist, patient to physiotherapist, caregiver to physiotherapist, patient to physiotherapist through a health worker, and physiotherapist to physiotherapist. Now, patient to physiotherapist means the one who already knows what is his problem and is actually having some kind of what you call judgment. So he himself will give a call to a patient, to a physiotherapist, to establish the diagnosis of his problem. That means, say for example, a case of low back pain. I know that the patient is educated enough and he has called me, and I have also seen the patient before as well. I'll give you an example of a lady who had just called me some days back. She is basically my child's friend's mother. So she just had a fall while doing some work, bathroom cleaning or something, and I asked her detailed history, and I could make a judgment in terms of her diagnosis. So she was able to make a call and make a consultation on a phone itself. But just imagine if it was a previous patient that I talked about, the stroke patient, and he was only having a caregiver at a home at that particular point of time. Will a stroke patient be able to give a call to a physical therapist at that particular point of time? Not really. So it will be his caregiver. He will try to give certain clues to his caregiver to make a call to me, so that I will have to now judge what are the abilities of the caregiver and how much will be he or she be able to assist at that point of time. Next is patient to physiotherapist through a healthcare worker. Like for example, if Himanshu sir refers a patient to me from Kota, so naturally I will have to assess that patient, and that will particularly fall in the category of physiotherapist to physiotherapist. But a patient to a physical therapist will be through healthcare worker. Like for example, a nurse in the middle of the night in an ICU gives you a call that, see, this particular patient on various what you call suctioning devices and all needs certain help. So you will first analyze the situation, that what really it is, and maybe you will judge that yes, patient needs more of suctioning. So you will give the right kind of direction to that particular nurse how you're supposed to do it. Or if there is any physiotherapist on call available in the patient in that particular ICU, you will ask him to go and talk to that particular nurse at that point of time. Next, please. Now coming to the details about asynchronous and synchronous mode. First, the asynchronous. Asynchronous telerehab is also called as store and forward type. Here the information is recorded and transferred, and it can be stored locally or in the server depending on the availability. Like for example, whatever videos I had made previously, I have already stored it with me, and I am now transferring them to the patients. They can also store them, and they don't need the connectivity whenever they want to look at it, because they've already downloaded it and they can see it at any time. There is a time delay between the message which is sent from one party and when it is sent by the second party. And the common store and forward technologies used are messaging, emailing, or web-based self-management programs. Like for example, these days even the sites like YouTubes have also become very good in treating patients. You see, anybody picks up anything pertaining to their condition, and they start treating themselves. But then there is a caution that they have to be sure whatever they're doing is correct. Next, please. Newer technologies such as virtual reality or wearable use store and forward technology to transmit data back to the therapist. Like for example, you say some days back, our own Professor Sanjeev Kumar sir had actually given a presentation regarding this virtual reality. Here, we can put a patient in a scenario which can be two-dimensional or which can be three-dimensional. So depending upon the availability, if you have certain video games, you can send it to them, and that virtual reality will really help them. I mean to say, you're already having it and you are forwarding that particular information to them in terms of the video games, etc. Like for example, for balance and coordination. And that is the real virtual reality which is helping the patients to enable them to become more functional. Then viewing and commenting of the data can be done at the participant's end. Naturally, now once the patient will view it, he or she will be able to only comment for that after receiving it, not in real time. It is less dependent on connectivity, and it has more difficulty to administer. Now, why I say it is more difficult to administer is because both the parties are not there then and there in place. So you have to write down the comments and then reach out to the therapist who has, made that video, and then ask him the question. Software choice and interconnectivity standards plays definitely a role. Say for example, if it was email, somebody has questioned me that I have this problem and what I do on just an email, so I have to use an email interface to answer. Okay, that becomes more challenging for me than even audio call, right? So audio call, I will be able to take the detailed history at least, isn't it? Next please. Coming to the next one, that is real-time or asynchronous telerehabilitation. Information provided by one party is received almost instantly by the second party. That means, of course, it is a live video conferencing. So whenever I can see and interpret, I will definitely try and tell that to the patient then. So information or data is transferred live. It is convenient and easy form of telerehab, and it requires high bandwidth. Now here is the example that I can give you why we have chosen to switch off our video to retain the high bandwidth. Because if we would switch on our videos, our connectivity will drop, because we are doing a live session. Of course, this is a live education system. This is not a live diagnostic session or treating session, but this is a live education system. To retain connectivity, we are switching off the videos. So it has constant connectivity. You have to invest in related hardwares, because nowadays obviously most of the people have what you call smartphones. But telling you a fact, in India, how many people actually have access to the smartphones? This is the second question that I'm asking the audience. You can write in the chat box. Maybe not more than 30% even. Maybe not more than 30% even. So definitely it makes difficult. No, it's not 70%. It's very, very less. So it makes difficult for them for taking the e-consultations. But however, obviously in future, it will progress to higher numbers. Now, video conferencing, between patient and healthcare provider is a prime example. Physiotherapist and client can see and interact with each other. That's what I was just saying. This is more prevalent in physiotherapy for heart and lung diseases, diabetes management, and musculoskeletal conditions. For example, osteoarthritis, and for the rehabilitation of patients after the orthopedic surgeries. These are just few examples to list. There could be many more examples that we could state. Next, please. Next, please. So the next slide is not yet displaying. Okay, that's the time lag. Okay. Now coming to the terminologies that I used. See, I told you previously that this particular e-technology or e-digital physical therapy service was already created by WCPT way back in 2017. So therefore, there are various terminologies that are used in US and other parts of world for medical insurance companies by different names. The number one is true telehealth visit. Now see, the term true is very important here. What is true telehealth visit? This is real-time, synchronous, using two-way video, not only for establishing patient, and does not have to be patient initiated. That is, it is the responsibility of the healthcare professional to initiate a video conferencing for both the parties, so that they can use a real-time synchronous way to judge what is the problem, to take a detailed evaluation, to take a detailed assessment, to take a detailed history and the function of the patient, to make the correct diagnosis. So this is a paramount. For every first consultation of every new case, true telehealth visits are must. Next is e-visits. This is asynchronous assessment and management via information exchange, and it and secures messaging, patient portal for patients established only or patients initiated. So that means those who are already known, for them we can do e-visits while texting also, or even the patient can initiate that, okay, what am I supposed to do next? This is just for the follow-up patients. Next is virtual check-ins, real-time audio only call on phone, but not the video. This can be supplemented by recorded videos or
Hope there is a connectivity issue. Soon we would be able to hear the ma'am. Kindly be patient.
hello.
Yes, ma'am. Audible, ma'am.
Sorry, I got unmute.
Okay.
I got mute. I mean,
Okay. Nice one.
now coming to the virtual check-ins. This is about real-time audio-only phone calls. This is done through phone calls, secure messaging like portals or email. The example of the email that I was taking, that is virtual check-in, that you just call as virtual check-in if you're using that particular system. Then remote evaluation of images and recorded videos. Again, since the word remote is there, that means the patient is at a distance, and thus you may require both synchronous as well as asynchronous medias via phone, real-time videos or audios, text, secure messages or email. So maybe it's basically uh, all of them, all of the methods, whether it is synchronized, asynchronized, or even the different types of these are used to establish the right diagnosis and the treatment plan for the patient, and even for the re-evaluation and the assessment and the patient management. Then is the telephone visits. This is also synchronous real-time via telephone for establishing the patient only and patient initiated. That is the phone calls that we receive from the patient party. And then online digital evaluation and management services. Here we do the assessment and management via the information exchange and secure messages for established patients only and the patients initiated. So you can see, if you go from up to bottom, the first true telehealth is the most important of all for the patients who are visiting you for the telerehabilitation for the very first time, and depending upon the complexity and the nature of the diagnosis of the patient. Next, please. What are the factors influencing the choice of telerehabilitation technology? Now, there are another factors like task, interaction, stimulus, type of response, and technical function that also is responsible for telerehabilitation. That means we have to judge what are we supposed to do, what is our action, are we going to assess or manage. You can go to the next slide. There is a diagram in that. And then the interaction. Who are interacting? Is it a physiotherapist and patient? Himanshu sir, you can go to the next slide. What is the stimulus needed for the interaction? Is it only a phone call or a video demonstration or a real-time demonstration? Or what type of response do you need from the patient? And what is the technical function to facilitate the interaction between the physiotherapist and patient? All these factors will determine the type of the rehabilitation that you will look for and the media and the mode that you will take up. Next slide, please. Himanshu sir, please go to the next slide. Yes, this is the diagram that I was talking about. That means all these will influence the telehealth choices. Go ahead, please. Next, please. Now, see, to determine how to use the type of technology, you will have to enlist. That is, you'll have to make a list of a specific patient type that you are trying to treat. That is, if it is only a follow-up case, if it's an emergency case, if it's someone who needs immediate consultation, what is the age of the patient, looking at all the barriers and challenges which are involved in teleconsultation, you have to think and enlist what will be your priority. And for each of these assessment tasks and management strategies, think about the interaction needed with your client. That is, you will always make your question prior if you know what type of patient you are going to interact with. How do you need to interact with your patient? Put the assessment task and management strategy task done in an asynchronous mode or a synchronous mode. You have to always answer this question before. What will stimulate it, whether you want a call from the patient or whether you will call, and consider a specific action that you require from your patient in response to the stimulus. Of course, then the chain of reactions begin, and the technical requirements which are needed for the same. Next, please. Now I'll give you an example here. This is an example of orthopedic post-operative patient of a TKR, total knee replacement. Now consider the factors listed earlier when consulting with a orthopedic post-operative patient or with a physiotherapist post-operative. You know your task is to analyze the movement, that is movement analysis. So what is the interaction needed? Can the patient record a video of a specific movement and send it to you via asynchronous mode? Is it a real-time interaction needed in order to take the feedback then and there and cue to the patient to control the movement? Like for example, if I had known that there is an extension lag, so I had to judge it using the synchronous mode. So therefore, I will make sure that whether I have to utilize a video call or just a asynchronous mode. Next is the stimulus for the patient. Does the patient only require instructions for a specific movement or video of the movement needed, or is it a real-time feedback? And then the client's response. Active movement, can the patient start it by himself, or is it the caregiver's responsibility to start and initiate and then supervise? So you think about those parameters. Then the technical function needed by the telerehab system, as I enlisted all of them before as well, real-time platforms, measuring capabilities. Measuring capability is basically the function that we are looking at, whether it is ROM, whether it is strength, etc. Or is it only still images which will help us to make our decision? Because clinical decision judgment is very, very important. So selecting a suitable platform for telerehabilitation. Next, please. So you have to look at the availability, you have to look at the privacy and the security, you have to look at the ease of use by both the parties. It's not that I have the autonomy because I'm the physiotherapist and the poor patient is a client. No, we have to look at the autonomy of the patient as well. So cost, interoperability, like for example, if the patient has the media but he doesn't know how to use it, or say if the patient, even physio doesn't know, the first year student, second year student, third year student, I am not sure how many of them are actually using this real time technology at this point of time. And the medical legal aspects, which are the most important things one has to keep in the mind while giving the telerehabilitation. This was the part which would have been, I think, probably maybe important for you all. We thought so. And I think you are the very wise people to judge it. And the next part will be discussed by Dr. Jitnder Munjal. So now I'll hand over the platform to Sir. Himanshu sir, you may please unmute.
Yeah, thank you, sir. And thank you, Dr. Kalpana, madam, for giving a detailed view about the telerehabilitation. So as you can see from the diagram, nowadays, as all of us know that the technology is advancing day to day. Hello? Yeah,
Yes, sir.
yeah. Uh, yeah, can you please change the slide, sir?
Okay, sir. Okay, sir. Okay, sir. Is this
Next
for
one,
the
next one, next,
next one? Is this
next one, sir. Yeah,
progression of
okay.
technology?
So the Yeah. So the technology is advancing from day to day. As our Prime Minister has also said that digital India is what we dream about. So we can see from this picture that initially it used to be a telephone and a pre-recorded video material that used to be sent to the patients. So this was, I'm talking about, in 1980s. And after that, with the advancement of technology, we can go for live video conferencing, web-based interactive softwares, text messaging technology, sensor-based technology, and virtual reality environment has come up. Now, what is this virtual reality? As last time sir had also told that it is a 3D analysis, 3D analysis. So we can visualize what is the patients, we can evaluate, and after that we can give our recommendations, and the patients will also get like, will have interest in the treatment. And now with the coming of the smartphones and applications, things are very much easier and more convenient for us. So recently there was a study that was a RCT done by Russell et al. In 2011. So they studied they studied two groups. In one was the TKR with smartphone rehabilitation, and the other was with normal in-person rehabilitation. So they found that there was not much of a significant difference between the two groups. That showed that as per Russell's RCT, that smartphones are equally effective in treatment of post TKR patients. So this is a great achievement. So next slide, please. Sir, next slide, please. So this is a great achievement of the telerehabilitation, and that has been scientifically proven also. Now, what are the available telerehabilitation platforms? Now, there are many telerehabilitation platforms available as listed below, and these are the cloud-based, that is Covio and Doxy.me. There are app-based, that is a PhysiTrack, and they are embedded in practice of software management. These are Clinico, but these are all paid softwares, so you have to pay, and then you can use this platform, and they are specifically for physiotherapists. Next slide, please. Yeah, these are the common publicly used platforms. They are available free of cost, but all of them have advantages and disadvantages. As you can see, first and the foremost is Zoom. Now, what is the advantage of Zoom? It is less streamlined, and it has to be downloaded for the first time, and after that it can the client does not have a difficulty, and they can always approach as and when it is convenient for them. This is designed for meeting and webinars, and this works for group classes where it is not likely that sensitive information is shared. Now, there have been media reports where the security breach has been there for Zoom app. So calls may be encrypted by default. So in order to overcome this, there is Zoom for healthcare services. But the thing is, this higher subscription fee is there. This integrates with some physiotherapy software and gives higher level of security with HIPAA compliance. Now, what is this HIPAA? This is our regarding our ethical considerations. So I'll be discussing this. This is Health Insurance Portability and Accountability Act, and this is prevailing in the US. So next we have FaceTime. FaceTimes are the clients can reach you anytime they want. So this is not advisable because the physiotherapist gets privacy is gone. The data can be stored on iCloud, and this may again lead to legislative issues. And they have had security flaws in the past with FaceTime also. So this is also not very much recommended. Then there can be Skype, but the thing is there is poor quality of calls in Skype. Privacy and security issues are there, and the data is vulnerable. Now, this is the most easy and convenient WhatsApp mode that I think most of us are using. So there is one application that is to be downloaded, and that is connected to mobile numbers. And I think 90% of the people who are having smartphones have this app in their phones. But again, issues for data security are there, and the compliance is not very, very good. Next, we have Microsoft Teams. This is more secure than the Skype. This can be, but the setup can be tricky. So what is this? User friendliness can be an issue. So while considering your commonly used platforms, you have to see that you have to use your own phone in consultation, and you have to have a private number for your security issues, because data, if at all it is shared, then you are in for a trouble. That I'll be discussing the ethical considerations later on. Next slide, please. Now, coming to the summary on the use of platforms, as I told you, there are many available platforms for video calls, and new ones are created day by day, and there are existing ones which are undergoing changes, and we have to be careful with regards to security, functionality, user friendliness, and the quality of this platform. Now, it remains your responsibility, I'm stating it again, it remains your responsibility as a healthcare provider to ensure that the privacy and the security of sensitive health information of your clients, and there needs to be the key when considering what platform to be used for telerehab. Next slide, please. Yeah, these are the key principles what have been listed for implementation of telerehabilitation. First is administrative. Now, looking at the administrative point, first of all, that we should be aware of the laws and regulations that comply to the information and communication technology, the ICT technology that we are using. We should know what are the laws and the regulations that are prevailing for them. As I told you, there are certain disadvantages and disadvantages of each of them. Now, you have to be aware of the state and federal laws about the telerehab prevailing in your country or your state. You should be aware of all operational and contractual requirements for telerehab. You should be aware about the billing and the coding process. This is very, very important, because the thing is, especially in case of US, where there is a insurance is there may be companies who may not pay for the insurance for the telerehab. So you should be aware of what kind of billing is to be done and what is the coding process for that billing. You should be aware of the safety, security, and confidentiality of each and every data and whatever you are collecting from the patient. You must ensure that the clients know their rights and responsibilities, because the thing is, tomorrow the client should not know that should not say that you gave a tele-rehab session and I needed I needed a in-person session. Now you have to ensure a caregiver is available. So whenever you're going for a tele-rehab, you have to have, the patient needs to have a caregiver, so that who can be made to understand that these are the points that are to be considered. You should have mechanisms in case of emergencies. Suppose a patient is calling, as madam had already given example, a patient is calling that he's having an injury, he's had a fall and he's fractured his both bones. So you should see that the emergency care is available. Probably you can only tell them that this is the hospital or this is the clinic nearby which can cater to your services, and you can always contact them. Performance and quality improvement measures to assess telerehabilitation services should be there. Now coming to the clinical principles. Now the healthcare professional should be trained in equipment of software and ICT, that is the communication system and the troubleshooting. If a healthcare professional does not know what is the equipment and how the software is working, obviously he can hang on and he can lose the data, or maybe he may share the data with somebody else. So the healthcare professional should be well versed with the equipment and the software. Now, how to operate the video and the confidentiality and data sharing should also be known to the healthcare professional. Whatever technology you choose, you should be able to switch over from synchronous to the asynchronous mode, and if the need arises, it should be vice versa, from asynchronous to the synchronous mode as per the clinical requirement. Now, there can be technical principles, that is, you should comply by all the rules of all the technology. You should ensure that all equipment is safe to use. Infection control measures should be taken into consideration for tele-rehab equipment, especially in this COVID era. Okay, you need to see that the same instrument or same telerehab equipment other physiotherapists are also using. So you have to be careful in case of infection control measures. Then you have to be careful about the security, confidentiality, about the data sharing and storage. And the most important is the ethical principles that need to be applied. So coming on the next slides. Next slide, sir. So these are the ethical and professional considerations with telehealth. Now, taking them one, as I told you, scope of practice, madam has already discussed that the person who is registered with the respective council, respective state bodies or respective associations can only practice the telerehabilitation. Next is your patient consent, privacy, technology security issues, equitable access to technology, and professional regulations and indemnity. I'll discuss this in detail. Next slide, please. Coming to the patient consent. So prior to any treatment, you should consider the patient consent. So if you are in a tele-rehab, that doesn't mean that the consent of the patient is not required. Rather, this is more important. Because the thing is, tomorrow, if the patient comes and says, no, you did not give me much benefit, and I think physical benefit would have been better. So you have to take the consent, and you should already clearly tell the patient that there are these two options, and if you want to go in for person treatment, then this is the option. But since due to disability, or maybe due to distance, or maybe due to lockdown, or maybe other constraints, if at all possible, then telerehab can help you in this way. So you have to tell clearly that how will you provide the treatment. Then you have to discuss with the client why you plan for telerehab rather than in person. And if you need to obtain a written or a verbal consent prior to commencing a telerehab session, that is your decision. And at the same time, you can take additional consent for video recordings or images, because the thing is, if at all you're recording a video or you're taking a picture, tomorrow again the client may come and sue you that why did you take my picture, what for have you kept the data. So you have to give clear instructions and take permission for all these things. Next slide, please. Now coming to privacy. Privacy concerns arise when adopting telerehab. It is therefore essential that you uphold the same level of privacy and confidentiality for telerehab consultation as would if you were treating the client in person. As you know already, while giving in-person treatment, you have a separate cabinet, you have a sister present, if at all it's a female patient. So you have to maintain the same confidentiality and same privacy guidelines as in case of a personal treatment. Okay. Now, technology and security issues are important to consider in relation to privacy. Particularly, telehealth consultations involve a greater number of parties than face-to-face healthcare interactions. Like the thing is, if at all a caregiver is present at home, or there are other family members who are at home, and the patient is not able to like tell all his problems. At the same time, when you are doing a tele-rehab session, there may be other colleagues of yours who are sitting beside yourself. So you have to make sure that the privacy of the patient is maintained. So you can ask the patient clearly whether he wants that some caregiver should be there or doesn't want. At the same time, you should see that the safety of the patient is not compromised. Now, on a more basic level, it is essential to consider that the patient's environment before commencing a tele-rehab consultation. They need to be able to access a private space. As I told you, privacy of the patient is must, so that others are not private to the consultation. Next slide, sir. Now, technology and security related issues. The use of tele-rehab creates many issues in the relation to privacy and security. As health care providers, we need to consider whether or not the platform we are using is secure with end-to-end encryption. That is, end-to-end coding should be there, and the platform and the technology should be safe. Now, storage of electronic information also needs to be considered. The patient information like notes, photographs, and videos must be stored in a secure location so that all the clinicians involved with the patient's care can access them. It shouldn't be like the data is open, your computer is open, your mobile is like, everything should be locked, or maybe with thumb impression they can open. So you have to store all data very, very safely and with the consent of the patient. Next slide, sir. Now, equitable access to technology. Now, the issue of access to technology is a very, very important thing. That is, the patient should be able to access the technology. The physiotherapist, whoever is the consultant, should be able to access the technology. Like it should be whether real time or asynchronous mode. So all the access to technology should be there. The cost of the equipment. Now, this is an important thing, but as of now, as on date, with coming of the smartphones, this has relatively come down. But this also matters in case when the patient is going. Suppose we have a sportsman, we are supposed to analyze him on the field. So we need infrared gonimeters to assess him, to see his motion analyzer, and we should see. So that time the cost of the equipment goes more. So we should be careful about that. Skills to use these platforms. Again, I'm telling you the same thing. If at all we need a motion analyzer, or we need to use an infrared gonimeter, so we should be skilled enough to analyze each and every movement and the motion that the patient is doing or the subject is doing. The ability to operate technology well enough to ensure that the call video quality is adequate. This includes ensuring lighting, camera resolution, camera height, and audio quality are all good, so that you can properly assess and evaluate the patient, and at the same time you can easily demonstrate or convey the message whatever you want to give to the patient and give maximum benefit to the patient. Next slide, sir. So next slide. Yeah. Now, coming to professional regulations and indemnity, because telerehab is rapidly evolving and has not been previously used in some regions, your professional indemnity insurance may not include specific clauses relating to the provision of digital health. This is again the same thing. Reimbursement could be a key challenge, as I told you. Like there are insurance policies, even though they are coming up in India, but still telerehab, they do not just pay for the telerehab. So it may come out from the pocket of the patient. So you have to be careful while charging them, while billing them, and at the same time, you must try to keep the rates low only. In order to ensure that you will be paid for your work, it is important to have good understanding of variations in telerehab reimbursement rates. Next slide, sir. Now, data security in telerehab. Now, these are two foreign bodies which actually regulate, and still in India, we do not have these bodies. One is your HIPPAA, that is Health Insurance Portability and Accountability Act. This is a US law. Now, what is the purpose of this law? This ensures that the healthcare worker keeps the health information safe and protected. Healthcare worker keeps the health information safe and protected. Mind it, just keep it in mind. Healthcare workers are in HIPAA covered under the entity. Okay, so they are covered with HIPAA entity. They provide the providers of assistance and support to the healthcare workers are business associates. So they label them as business associates. And we are required to sign a business agreement with the technology platform or business associates so that everything is goes on with the HIPAA guidelines and there is no breach in the safety and security of the patient's data. Now, in Europe, we have the GDPR, that is General Data Protection Regulation. And under the GDPR, healthcare provider is known as the data controller. He is the one who controls all the data. So the data controllers have specific legal obligations such as the right to forgotten. This allows the data controller to delete patient information upon request. So we have to see whether the data is to be stored, and if the patient says that we have to delete the data, means we have to delete it. Next slide, sir. So this is the Data Protection Act. Now you can see in the figure, the center is the data protection principles. Now what are they? First is used fairly and lawfully. So I told you that we have to take the consent and we have to, for the consent, whatever, whether we have taken the consent for the research or we have taken for patient treatment, we should clearly take the consent and use it for fairly for that purpose only. And it should be used lawfully. When used for limited specifically stated purpose only, it should be used in a way that is adequate, relevant, and not excessive. Okay, it shouldn't be like if at all I'm supposed to evaluate, I wish to know the just the MMT and the RM. It shouldn't be like I ask the patient to show his entire posture and each and everything, or maybe ask for other details. And it should be accurate in the diagnosis. Whatever data we are collecting should be accurate. Next is it should be kept for no longer than the absolutely necessary time. So when the treatment phase is over, follow-ups are over, we should try to discard the data unless and until we want to keep it for further for research, and that too with the patient's consent. And it should be handled according to the people's data protection rights. As I discussed earlier, you have to take care of everything: consent, privacy, and data storage. Next slide, sir. So the suitable video platforms, security and privacy of client data records are paramount in the healthcare. This does not change when consulted via rehab. Safety and security with video platform is therefore extremely important and a necessity. Okay, so it is important that the video software and the platform that you use must be encrypted, not interceptable, and not hackable. Mind it, the video software platform that you use must be encrypted. Coding should be done. It should not be interceptable and not hackable. And you as a practitioner may be held liable for sensitive information if at all it is not well protected and if it is lost. Next slide, sir. Next slide, sir. Now, the platform security, the practitioner has to demonstrate that the selected platform is secure and private. That is why I had earlier mentioned which is the platform that is secure, which is more private, and what are the advantages and disadvantages of various platform. And end-to-end encryption is necessary. And during COVID-19 crisis, the need for this comprehensive assessment is relaxed, specifically in the USA, but it will return to normal again afterwards. Okay, so the thing is, the US government has relaxed certain guidelines for carrying on the assessment in case of COVID-19 crisis, but that will again the same laws will come into effect after the COVID-19 crisis. So you have to follow your country or the state guidelines regarding GDPR or BAI agreements or HIPAA. In India also, the state councils like the DCPT and OT, that is the Delhi Council for Physiotherapy and Occupational Therapy, and the Indian Association of Physiotherapists have given permission for tele-rehab during the phase of COVID-19. Now, next slide, sir. Now, the other considerations. Now, this is the most important thing. You should consider cultural specific issues. Now, first is considering if eye contact is appropriate or not. So you have to see what is the basic culture of the patient that you're trying to treat or you're trying to assess. So maybe there may be that eye contact is considered offensive in some classes. So you have to be careful about that. You have to check if at all it is acceptable to record images. That is again as per the cultural guidelines. considering whether patient would prefer a therapist of a specific gender. There may be female therapists who may need a female therapist only for the assessment, a patient who may need a female therapist. So you have to be careful while selecting your uh, data and considering the patient. Now, if at all translator is required, that is again a very important thing, because probably if at all the caregiver of the patient, he may not be able to explain everything clearly, and you may have difficulty in assimilating information from him. So in that case, you need to have a translator with the patient. Now, next slide, sir. Now, what are the factors that affect the compliance of a telerehab? Now, we have studied telerehab in detail, but we need to take care of certain factors that are important for compliance of telerehab. First is age. Now, there are elderly population who may be reluctant to do exercises, who may have difficulty in understanding. So, age is an important factor. Next is gender. There may be females who may be little less curious to do the exercises, or there may be males also. At times, they may be reluctant to do exercises. So gender is another important thing. Next is low levels of physical activity at baseline. If a patient is not doing any exercises previously, so if at all you recommend him an exercise program, he may be reluctant and you cannot follow up. Next is poor social support. If the family support is not there, caregiver support is not there, they're not helping him to follow the rehab protocol that you're giving. So in that case also, the compliance will be less. There can be greater perceived barriers to exercises and poor understanding about the condition. The patient may say that, no, I don't have any problem. I don't think I need these exercises or this protocol. So there can be poor understanding. Or if at all you try to make them understand, still they won't understand. That difficult to commit to the time needed to exercise. If you're giving a rehab program that you need to exercise at least 30 minutes or 20 minutes a day, probably they may be difficult. They'll say, I'll do it in the afternoon, I'll do it in the evening, and this way they can miss the protocol. Next is high cost of treatment. See, these are two different things. Initially, we were telling that we should go in for low cost treatment. Yes, we should keep our fees low, but at the same time, there is high cost of the infrastructure that is required. That is internet connectivity, electrical supply, then the caregiver who will be taking care of the patient. Plus, at the same time, there can be big instruments that may be required for videography and all. So all these things should be considered while looking into the compliance of the tele-rehab. Next slide, sir. Now, the future areas for research in tele-rehab are: first is demonstrating equivalence of assessment and therapy in person assessment and therapy. This I told you that RCTs have been done in 2011 in abroad. So this same area of research can be followed in India also. Next is building a secure and confidential new data collection system to digitize information that a therapist can use in practice. So we can get more and more information and data, but that should be kept confidential and with consent of the patient, and further research can be carried out. Next slide, sir. So next slide. Yeah, concluding remarks. With the ever-enhancing realm of technology and tele-rehab applications, the future generation of physiotherapists must be aware of the evolving changes in technology to make physiotherapy an interactive environment with the patient. So you should be aware that the technology is evolving and changing, and physiotherapy profession should also be changed, and it should be a more interactive environment with the patient so that the patient has interest in the treatment and he can follow up nicely. And this is going to support an increase in motivation and facilitate participation in home exercise program, because tele-rehab is easy to be done at home, but at the same time, compliance is must. As one review discovered, non-compliance remains a major issue in improving healthcare outcomes, despite many studies highlighting this ongoing issue for over the years. So again, compliance is the key. You have to take care that the patient is compliant, his family support is there, and he can carry on with the tele-rehab at home. Now, during the COVID-19 crisis, as I told you earlier, there have been advancement in telehealth services like in Australia, England, and the US, and they're facing challenges. Similarly, in India also, the Delhi Council has already given its guidelines for tele-rehab and the permission to physiotherapists to carry on with the tele-rehab. I think the session is concluded and it's open for discussion. If any doubts, queries, or questions are there, Kalpana madam is also there and you can unmute her, and I can also take the questions. Thank you, sir. Thanks all the seniors for patient hearing. Next slide, sir.
Thank you, sir. Thank you very much. It was a very informative session. And again, we have a great learning in this session today. has been delivered by both of you, and definitely it is a much needed thing in this COVID scenario. We must know about the telerehabilitation. Actually, what is a telerehabilitation? The word is introduced, but not the basics we all know about. So we are really grateful to both of you for sharing the actual knowledge about the telerehabilitation. What are the actual platforms available? So if someone, as we are sometimes practicing the properly the telerehabilitation or maybe the improper way. After this session, definitely we will have more accurate learning how we can effectively use the best ways or best methods of doing working with the telerehabilitation. Thanking you both for such a great session. And
Master, I think if you can play a video, I would like to comment on that video also,
yeah,
the
yeah,
video
sir.
that I
So
had given.
okay. So
Just for
should I
two
play
minutes.
that?
Yeah, you can play that.
Okay,
Actually, I'll tell you, this is a patient who is in US. Okay,
okay,
so during the COVID time, that is I think March, sorry, May end, he had this Bell's palsy. So he was recently married, and the couple did not do what to do at that time, especially in US. They did not have approach to the hospital in US because everything was locked up. So what they did was, through some relative, they tried to contact me. Then they told me that once they went to the doctor over there, they had the prescription. Then they had told me that this is a prescription. Then I made certain recommendations in the prescription, and somehow through teleconsultation, they got in touch with the physician, and the physician accepted the changes that I had told them. And at the same time, the entire rehabilitation, that is the exercises, massage, precautions, strapping for the face, everything I told them online only. And this patient has sent me a video. He's recovered 80% in just 3 weeks. That was in June. He's recovered. And after that, the initial video that was for his Bell's palsy, the initial video that was his Bell's palsy, I had to delete because initially I had not taken his consent because data storage was a problem. This is the video that he's recovered almost 80%, and you can see his left side. It is still problematic, but the thing is, as on date, he is 100% fine. So this is what is the advantage of telerehabilitation I wanted to convey to you. You can see his left lower quadrant is the one that is affected more, because this is in after the rehabilitation phase. Means half the treatment is over. This is after 3 weeks. I had the initial video also, but due to the privacy guidelines, I had to delete it. And after that, I took consent from him to show it to you. And now you can see how he is. And as on date, this is again in first week of June. And 3 weeks prior to this, he had the attack. And he was very, very much in anxiety and distress that how will I join my office once the lockdown is over. And I told him that he'll be fine in 4 to 6 weeks, and that is what has happened. And he's almost 80% recovered in this. As on date, he is 100% fine. So this is what is the advantage of telerehabilitation.
great, sir, great.
And this is just one example. Like through telerehabilitation only, over the past 3 months, I've treated almost 25 patients through telerehabilitation only.
Oh, great.
Thank you. Thanks a lot. And any queries, you can always ask me.
Yeah, yeah. Now, if anybody has any query, they can ask, because there were a few participants who were, I think they are about to ask. And today we are having the participants from around the 4 countries, not from the India, even from the Malaysia, Saudi Arabia, USA, and Pakistan also. So I
Thank you.
think
Thanks to all the participants.
it was the aura of your session only, sir, because we had the great resource person for this session. So we had the participants from the 4 different countries, and then they had joined us. I would request Tarun Amalnerkar, sir, if they are available. Yeah, they are available. So you want to ask some query in the session. So I requested them to please keep it till the end. So Tarun, sir,
Yeah,
if it is
sure.
comfortable,
Kindly unmute Kalpana madam also.
Okay, yes, sir. Yeah, done, sir.
Thank you. Thank you. Thank
Most
you. Yes, please ask. Please ask.
yes. So, Tarun sir, if you are able to hear me, I think you can ask the query. Yes, sir. Hello, Tarun sir. Hello. Hello.
I think they've written the words
Yeah,
of
yeah,
appreciations. However, I'm not sure whether he's there at this point of
To hear me?
time.
yeah. Tarun
Yes,
sir
we
is
are
not
able
there.
to hear. Yes, please go ahead. Please go ahead.
Hi. Interesting to both the respective speakers. I really appreciate in the short given in the given time, like you covered quite well. So thank you for that. It's quite late, so I'm not coming on the video. Looks a bit like rusty. Okay,
No
so
problem. No problem. We are comfortable
two,
with it.
three questions here. The first thing is like when you do this exercise prescription, is more or less like about some demonstrations, or we talk about eccentric or concentric exercises. But like when we go in the depth of some manual techniques, do we prescribe and talk about that also?
All right. If I had to answer, see, of course, unless and until you're not sure that the type of manual techniques you want to give to the patient, because manual therapy I will impart with my own hands, right? I would not expect that patient to have manual therapy with a caregiver, because the caregiver is not certified in that manual therapy. So decision is lying with me, that I have to weigh risk and the benefit. If the benefit overweighs, and if I think that of course the caregiver will be able to give it, then only I will make sure and decide that okay, yes, you go ahead. Otherwise I will not. If it's a risky procedure, I will definitely not. Does that answer the question, sir?
Yeah, I got what you should say, and that means it's more on the technical aspect. When it's like in the jurisdiction, then you're going to cover. Otherwise, more or less on demonstration or synchronized or non-synchronized method. Is it the way?
Yeah.
Like say for rather than telling what is exactly when maybe a role a video you already have made and then you're going to send it or you demonstrate on your own, then patient follow, isn't it? Is it?
So we
Is it
have
the
all
one?
the options. Like we have pre-recorded also. At the same time, we can
Sorry,
give website links
with
also.
apology, but I cannot hear. Can you speak loudly? Sorry for that.
So as I told you, we have all the options. We can send video links from YouTube also. We have pre-recorded data also. At the same time, we can demonstrate as per the need of the patient.
Oh, okay. So it's more or less is custom made, isn't it?
Yes,
Yeah,
yes, yes,
yeah,
yes,
it's
yes.
custom-made, tailor-made for the patient.
Yes, it is
Oh,
tailor-made.
okay. Because sometimes we get these questions and we are not stepping into it like because it becomes a bit like medical legal. Then we are also coming
Very right.
online and they do something else.
So
What
this
was
is what the example that I was trying to give for the facial palsy. He was also stuck up the similar situation only because he could not approach anywhere due to the lockdown. So he had to obviously approach me, and then I had to give him the rehabilitation on the.
that's really commendable. Very good example. So can
Thank
be
you, sir.
like hands-on. We can see that the effect was quite effective. Maybe it will take some time. I understand.
No, now
Then
as on date, he's 100% normal.
two more questions. Sorry. I'll just take two more.
Please.
Okay, how do we do documentation? Like in case we shown the recovery, any example like outcome measure, you just do. I mean, like how you do the documentation of that. The patient has recovered this much. Like if you say, I think something you told, I couldn't get that slide. Maybe I missed that infrared or infrafill goniometer range you shown
That is
pre and
infrared
post
goniometer. That is in case of if
from
we
the.
have to do movement analysis in case of a sports person. Okay, then you do videography and infrared goniometers are available. So the patient is
Okay.
subject is running, and then you analyze his range of motion. His MMT also can be assessed, and that is the way you get data. Now, in the case what I was discussing about the Bell's palsy, this is just a qualitative assessment. Okay, so as per the patient's subjective reply, as far as my assessment is concerned, so they said they have recovered by 80%. I felt in this video that they have recovered by 60%, and within another 2 weeks, he was 100% fine. Actually, I don't have the initial video because due to the privacy issues, I had already deleted. But as of now, I've taken the consent, and then he said, "Okay, you can show my video." Otherwise, you could have compared both the videos, and you could have yourself realized that yes, what I'm saying is right.
Okay, okay. That's all done. If I have something, I'll get back to you on the email. Really appreciate you both because in a very short time, it's a very big topic, virtual reality, telerehabilitation. So you covered it and you glanced it. Really appreciate it. Okay, if I have some doubt, I'll get back to you on email. I
Definitely,
hope
sir. Definitely.
I'll not. Okay.
We'd love to.
Thank you. Good night.
Thank you.
Thank you. Thanks, Dr.
Thank
Imanshu.
you.
Appreciate it. Okay.
Thank you, sir. Thanks a lot for joining us long away from the Malaysia. And it is, I think, for the Tarun sir, maybe the 1 p.m. at night, 1 a.m. at night. Sorry.
Oh,
So,
he is really very dedicated.
He's really dedicated, like Dr. Himanshu.
Yeah. Thank you.
It is all
I was
your
looking for it.
blessings.
Yeah. Thank you.
So,
Yeah, thanks.
Thank you, Harsh, sir. And I can see your comment. And thank you, madam, also for giving us support and giving us the time to share our ideas and listening to us. Thank you, madam. Thank you, sir. And thank you, Himanshu, sir.
Thank you, Dr.
Thank you all the
Amita
other participants.
Sharma ma'am. Thank you, Tanvi Rajdeep ma'am. Thank you, Dr. Anand Mishra sir. Thank you, Harshdeep sir. Thanks one and all for being so patient, waiting till now.
Thanks. Thank you all for.
We are sorry we had a little lengthy sessions, both of them, yesterday also and today also. We kept you waiting.
Yes, sir.
We are sorry we had little lengthy sessions. We tried to cover as much as possible.
Actually, sir, voice was echoing. Can you please repeat? Okay. By the way,
I'm saying we are sorry that we had lengthy sessions. Both the sessions
No,
were
no.
lengthy,
no,
but
no,
we
sir.
kept you
Actually,
all waiting.
this is just because on the technical end, and the technicality is not never ever in our control. We have tried our best, and it usually happens. So it is even though we are really grateful to you both that even though you are having a short of time and you both has covered completely entirely the topic from the base to the evidences. So it is very tough the dividing the topic, and it is describing in a well explained way. So we are really grateful to you in such a very short span of time to describe all the areas of the topic in both of the days. So there is no late, sir. Actually, there is no late, and we are really grateful to you for.
I think Tanvi ma'am wants to unmute. She's written in the chat box. Kindly unmute.
Tanvi ma'am, okay, yes, sir. I'm just. Yeah, Tanvi ma'am, if you can hear us, you can unmute yourself, ma'am, please.
Hello.
Yeah, ma'am.
Yeah, good evening, madam.
Hello.
Yeah, good evening, madam.
Good evening, sir and ma'am. हाँ मैं ऋतु राजदीप हूँ.
Oh.
Okay, okay. I thought so. I thought so.
Zoom की
मुझे लगा कि मैं कहीं mistake तो नहीं कर रही.
It was very नहीं ma'am. It was very nice presentation, both of you. Thank you very much, ma'am and sir.
Thank you. Thanks to you and sir.
Thank you. Thank you all. Thank you, Himanshu sir.
So thanks a lot, sir. Yes, sir. Hello.
Okay, now we can conclude the session.
So thank you.
a lot.
Thanks
Thank
a
you, all
lot,
of you.
one and all. Stay safe, stay tuned. We'll meet again tomorrow at 2 p.m. On the exercise prescription and documentation and MSK. Thank you. Good night to you all. Thank you all.
Good night, everyone.